So welcome everyone. Thank you for joining us for today's presentation, Bladder Control and Pelvic Organ Prolapse. My name is Kelly and I'll be moderating our seminar today. We are recording this session and we'll make the recording available within 48 hours after the presentation, so you can look for a link to that in your email. Now, on the bottom of your Zoom window, you're going to see a Q&A box. We'd love to hear from you during today's presentation. So if you have a question, you can enter it there and we'll address those either during the presentation today or at the end. We will have a couple of dedicated times for questions. And for your peace of mind, your questions will only be seen by myself and the presenters, not the entire audience. So feel free to ask your questions as we go. And I do ask that you use the Q&A box and not the raise hand feature. We're not going to be able to turn on microphones or anything. So if you use that Q&A box, that ensures that we'll be able to see your question. Okay, so we're going to get things started today with a few introductions. Then we'll dive into our discussion on common bladder health issues and treatment, commonly asked questions relating to women's pelvic health. And then we'll end our session today with a discussion on pelvic organ prolapse. So I'd like to introduce our speakers this evening, Dr. Conrad Duncan. Dr. Duncan is a dual board certified in, I can't speak this evening, dual board certified in gynecology and female pelvic medicine and reconstructive surgery with extensive expertise in vaginal reconstruction and complex and minimally invasive gynecological surgery. Prior to coming to Ascension St. Agnes, Dr. Duncan completed 7 years in the Indian Health Service and started the urogynecology program at the University of Kansas. Dr. Duncan is a graduate of the Yale University School of Medicine. Dr. Duncan uses innovative surgical techniques and is a regional leader in non-mesh repairs of pelvic organ prolapse and stress incontinence. He has been named a Baltimore top doc in 3 different categories, including urogynecology. Dr. Duncan is joined today by Sondra Barker, a board-certified women's health nurse practitioner with Ascension St. Agnes Urogynecology. Sondra is a member of the American Urology Association and the Society of Urologic Nurses and Associates. She was recognized by the International Nurses Association as the top registered nurse practitioner of Baltimore in 2016 and has been named to the Marquis Who's Who in America list for 2021 and 2022. Now let's turn things over to Dr. Duncan and Sondra. Thanks so much for being with us this evening.
Thanks for coming this evening. We know everyone has a lot of things to do tonight, and we just appreciate you taking an hour of your time to hang out with us and maybe learn something, and hopefully or not regret that you've wasted an hour with us tonight. I think we're going to start off with Sondra to do our introduction and lead us off.
Yes, thank you, Dr. Duncan, and welcome everyone. Today, some of the learning objectives for our presentation. One, we want you to become familiar with the term urogynecologist and what we treat. Who do we call if you have help in some of these issues? Understand bladder, bowel, and prolapse issues that affect your quality of life, and understand the treatment options available for you for your bladder, bowel, and prolapse issues. So little housekeeping things. There are both patients and providers tuned in today, so please exclude the slides that might seem too medical. We're going to do about 15 minutes reviewing overactive bladder and incontinence, 15 minutes about frequently asked questions, and then 15 minutes on pelvic organ prolapse. Please ask questions, like Kelly said, to use the Q&A button. Nobody can see your questions or who sent the questions, and don't worry about any spelling or exact terms. We can figure it out and answer your questions for you.
Oops, sorry.
So if you want to watch any previous presentation, you can scan the QR code above with your camera or on your smartphone, or you can visit the website listed below. And we'll also update a QR code so that you can rewatch this one if you'd like to. So we're going to start out with some terminology. One is urogynecology. We're going to explain what that means. Another word for it is, some people will say, we're going to refer you to urogyn. That's also urogynecology. Female urology, female pelvic medicine and reconstructive surgery. And just to let you know that Dr. Duncan is board certified. Urogynecology has been a board certification since 2013, and he is one of the first pioneers of the board certification in urogynecology. So a urogynecologist is somebody who has specialized training in the diagnosis and treatment of pelvic floor disorders, which include urinary incontinence, which is the loss of urine when you don't want to, overactive bladder, which is a big combined term for frequency of urination, urgency of urination, getting up at night to pass your urine, or incontinence. Pelvic organ prolapse. So it means it could be your bowel or your uterus or your bladder that's falling out, or you feel pressure in the vagina, and we can help you with that area. Fecal incontinence is the loss of stool or gas when you don't want to, and vaginal surgery. The urogynecologist has advanced training in vaginal surgery. So these are just some terms that hopefully you'll become familiar with at the end of our presentation.
So I'm going to kick in here and kind of try to make some sense of all these bladder issues, because it becomes very confusing for patients, and even our providers refer to us don't quite get it right all the time. So we're going to try to make it as simple as possible, but have it make sense for everybody by the time we're done. When you think of the bladder issues that you might have, they kind of break out into two categories. One is that you have frequency and urgency. The bladder is just frisky. It's literally an overactive bladder. That terminology was invented by industry, actually, because medical people had fancy terms like detrusor, overactivity, and nobody knew what that meant. Industry said, no, it's a simple thing. It's an overactive bladder. And then you saw the commercials, you gotta go, gotta go, gotta go, gotta go. And they were the ones that pushed the entire recognition of this problem into the public sphere. Kind of like Viagra did for ED. I mean, who knew there was ED until, Bob Dole had it? I mean, industry sometimes is a leader and we follow them. And they came up with the term overactive bladder. So that's the one category we're looking at. And the other category is you're wet when you don't want to be. That breaks out into two different types. There's urge incontinence, where the bladder, which is a bag made of muscle, just decides it's going to contract on its own and you pee on yourself. And then there's stress incontinence, which is a bad term because it's not like you're under stress. It's just stress forces push the urine out, coughing, laughing, getting up out of a chair. So this Venn diagram here that Sondra hates, I think it reminds her of high school where she failed this, but this diagram here will kind of sum up everything for us. This is the big blue box or circle is the overactive bladder group. That's everybody who has frequency and urgency. You're overactive. Within this blue box, you can be dry over here to the right, meaning you just have the symptoms of overactive bladder, but you're dry. You can have overactive bladder and be wet. That's in the middle, meaning you have overactive bladder and you don't make it all the time. And then this red circle over here, that's the stress incontinence group, meaning laugh, cough, lose urine. Obviously, those patients are wet. And this group in the middle, this purple group, they have both. And so a lot of patients have both. And it's really actually interesting because providers will get patients with both and not have any clue how to even begin to diagnose this. They don't have to. And you don't have to. Just if you're wet, you come to us and we will figure out what kind it is. Just a little reminder that this condition of overactive bladder alone, this doesn't include your incontinence patients, just your overactive bladder, 33 million people in the United States. That's a lot, more than heart conditions, asthma, osteoporosis, or diabetes. So it's a very, very common problem. You should not be ashamed. This is a lot of company you have. If you don't believe me, and not everyone believes everything I say, this is the incontinence section of every drugstore everywhere on a Friday. You go there on Sunday, it's pretty empty. So not only do we know it's a problem just by the statistics, again, industry, products, everybody knows that Incontinence is a huge problem for women. This is one thing that we just want to do a little sidebar. Nocturia, which is our fancy word for peeing on yourself at night or getting up at night to pee, is a huge problem. And it's just within the sphere of that frisky, overactive bladder. You're sleeping, and next thing you know, it's either a race to the bathroom or you wake up and your bed is wet. The reason I want to bring this up for our elderly patients, a real dangerous problem because you're a major fall risk. And every time that you get up to pee, you are a fall risk. And we have to really kind of watch out for that, be aware of that. Also, remember that getting up at night makes you not get REM sleep. And REM sleep is that good sleep that you get at 4 hours. And if you're not getting that, you're not getting REM. And REM, which stands for rapid eye movement, is the good stuff you need to replenish the body, to not be crabby the next day, and really stay healthy. So nocturia is a real health issue that, again, I like to focus on that because I'm thinking, like, if you're not getting REM sleep, if you're not getting good night sleep, then there are a lot of things that'll cascade down from that as a problem. These other things, skin irritation, breakdown, these are all consequences of being wet all the time. Let's talk about treatments for stress incontinence. And again, remember, stress incontinence, stress forces, not like you're under stress. The treatments for stress incontinence are pretty straightforward. Obviously, we want to try non-surgical methods first. Physical therapy is wonderful. Everybody should give that a try. Problem with physical therapy, huge time commitment, and good physical therapists are hard to get in to see. There are several non-surgical options too, including an incontinence pessary. There are things that can be placed into the vagina to help push up on the urethra, which is the tube where the urine comes out, and that will help you not lose urine. Incontinence pessaries are great for, let's say you're a runner, and the only time you lose urine is when you're running. An incontinence pessary might be perfect for you. So there are non-surgical options for stress incontinence. They are not medical, though. They are not pills. If someone gives you a pill for stress incontinence, they're missing the right diagnosis. So again, it's important for us or your provider to understand and acknowledge and know the difference between these two types of incontinence because they're treated completely differently. The sling procedure right in the middle there is our sort of surgical home run. And I say that because it's a very, very effective procedure, low risk, and almost always works. 30-90. It takes about 30 minutes to do, and it works about 90% of the time. So when I say it's a home run, we love that as surgeons to have a procedure that works almost all the time and takes a little bit of time to do and has very, very few risks. You may hear or see laparoscopic birch procedures offered. Well, you won't see that, but they are another option for stress incontinence. And urethral bulking is also another option. And the bulking is really just pushing some stuff on the sides of the urethra so that you don't lose urine. It just basically closes it from the outside. Going back to the sling procedure real quickly, it is generally done with a mesh. We have been using non-mesh procedures for the sling for over 10 years. So we, a long time ago, before the FDA said this was a bad thing to do, and actually banned it for prolapse use, we started using non-mesh procedures for our sling. We won't get into the details of that, but we have done more non-mesh sling procedures than anyone in the region. So are mesh procedures still available? Yes. Do they work? Yes. But then we have to deal with the issues surrounding mesh, a whole nother lecture. Briefly talk about treatments for overactive bladder and urge incontinence. Remember, overactive bladder, just think frisky. It's a frisky bladder. It's overactive. It's doing too much, kind of like your kids when they were 2, doing too much. Some overactive bladder patients are dry, some are wet. The wet group, urge incontinence. So overactive bladder, urgency, frequency, nocturia, getting up at night, urge incontinence, urgency, frequency, getting up at night, but you pee on yourself. So that's the difference. Again, same steps. We want to try the least risky things first. Non-medical management, meaning physical therapy, easy, risk-free, and works about 30% of the time. So it's pretty good start. The next level we have for this group of problems, the frisky bladder, is we can medicate you. We can give you some medicines that are pretty effective. Sidebar, if you're over 60-ish, do not take a class of medications called anticholinergics. And most of our medications for the treatment of our overactive bladder are anticholinergics. That's a group of medicines that older people, me included, should never take because it gets into the brain, makes you a little foggy. You included too, Sondra. Don't. It gets into the brain, makes you even foggier than normal. So you should never take anticholinergics as an elderly patient. They are a group of medications that'll dry your mouth out, cause constipation. Benadryl is a classic anticholinergic. It's not used to treat the overactive bladder, but it's one of those drugs that is a classic anticholinergic. Just dries things up. And so there's a second class of medications used to treat the overactive bladder called beta-3 agonists. That's the medical term. It's a newer group, works very well. And other than patients with uncontrolled high blood pressure or your insurance company doesn't cover it, it's a great, great group of medications to use. In addition, we have those last three things listed there are what we call level 3 therapies. If you fail those first two, or the side effects of the medications are too damaging to you, we have those three options, including Botox, which we can do in the office, and neuromodulation, which is a fancy word for saying we can put a battery in for your bladder symptoms. It's basically a pacemaker for your bladder. Works great. Almost all insurance companies cover it. And it's, again, an option if you fail those first two. This slide just talks about the things I already talked about. A reminder that the anticholinergics and the beta-3 agonists, that newer group at the bottom, can be used together so that if you're getting a moderate improvement with one, your provider can add the other class to help. You don't want to try to do two within the same class. So, and again, just a reminder that these classes of medications, a lot of you are on high blood pressure medications, and they're different classes. There's some that work on the brain, some that work on the heart, some that work on your blood vessels, and your doctor or your healthcare provider, nurse practitioner, PA will actually use different classes and put them together to try to get the best effect. And that's the same concept with these medications here. Again, the overactive bladder that doesn't respond to therapy, we can use the neuromodulation device to help us get you to where you need to be. Let's talk a little about fecal incontinence. This is loss of stool or gas when you don't want to. What's exciting about fecal incontinence, if I can say that, is that we have a therapy that works well for fecal incontinence that is non-surgical. And that's the role of, again, neuromodulation. The same device that we would use for your bladder, we can also use for fecal incontinence. So anyone with the loss of stool or gas, when they don't want to, which is actually a lot of people, you can see 1 out of 7 women older than 60 years old. That's a lot. Do we see them all the time? No, because they stay inside. It's an embarrassing condition, even worse than urinary incontinence, because it's not something you can totally hide. Urinary incontinence, you put on, it depends, and yeah, you have it, but it isn't necessarily something that everybody's going to know about. If you're losing gas or stool on your way out to the grocery store, so we don't see a lot of patients, people don't talk about it. It's not something you bring up at the cocktail party, but it is a very common problem, which is woefully undertreated and underdiagnosed. There's a complex workup, but again, the take-home message here is that we have some very nice, minimally invasive therapies for fecal incontinence. Patients who have both urinary incontinence and fecal incontinence, the neuromodulation is a home run, usually in those patients. This QR code, Kelly tells me it still works for previous presentations. She swore she tried it. And there's a web or a URL down there at the bottom If you want to take a screenshot of this right now, you can. So you have the URL, or you can always come back to it on the recording. I think we're going to go to some frequently asked questions. I think either Kelly's going to jump in here, or Sondra, or somebody. I'm tired of talking.
Yeah, I think you can run through these questions
Okay,
before, before we open it up for audience questions, just in
Okay.
case some of these might cover what the audience is asking questions about.
This
So
one,
I'll take the first
go,
one.
go ahead. Mhm.
What type of therapies for overactive bladder are covered by insurance? So each insurance is individual, as you know, with other things, but typically we need to try and fail at least 2 types of non-medical or non-surgical treatment options, such as if you did physical therapy and you tried a medication, typically then we can move on to the third line therapies, such as the Botox or the tibial nerve stimulation or the neuromodulation, as Dr. Duncan talked about. Sometimes we just only have to fail one if the other ones are not covered. So most of the time, some type of medication is covered. It's just if it falls in the anticholinergic group, where we don't always want patients who are in their 60s or older to be on. Or, we usually the newer medications, the Myrbetrix or Mirabegron, that one has gone generic now. So a lot of times we are able to get that one covered. We do need to try something for a minimum of 6 weeks before we usually get coverage. But each case is individual before we can move on. There are some home devices that are home pelvic floor therapy that you purchase and you can do on your own time at home, that as long as we have documentation that we have offered that to you and you've tried it, that we can usually count that too for our coverage for the things. But Medicare mostly covers everything that we have to offer. It's the individual insurances that have us sometimes jump through a little hoops to get you what is needed for your care.
Can tibial nerve stimulation work for fecal incontinence also? Duh, I just said that. This is like, yes, it can. Absolutely. It is a great therapy for fecal incontinence. It actually has changed our treatment algorithm, because we tend to use this as our first line therapy as opposed to the surgical repair of the muscles around the anus. It's much less invasive. It takes about 30 minutes to put it in. It's done in a trial phase where we put the wire in before we ever have to put the permanent battery in. And the battery is about the size of, yay big.
May I stop you for just 1 second?
Yes.
This question actually says, does tibial nerve stimulation work for
Oh,
fecal incontinence?
if I
And
could
so
read,
with
that'd be
that
dangerous.
being said, I'm going to interject that it has not been FDA approved for fecal incontinence in the United States. They are using it in Europe right now and are getting good success, but we have a difficulty getting coverage for fecal incontinence for the tibial nerve. That's the in-office procedure, not the surgical neurostimulation that Dr. Duncan is speaking of.
Yeah,
Sorry.
so thanks for correcting me. She does that all day long, corrects me. I don't know. She's very used to that. Yeah, 20 years of working together. Okay, so she did it politely. It was very nice. Okay, let's
This
go.
time.
I cannot empty my bladder all the way. Is that a sign of prolapse or a weak bladder? It can be. Urinary retention is the medical term for this, and it really requires evaluation. It might be from a weak bladder muscle, which can be helped with, again, neuromodulation, or it may be from prolapse, where you truly have a kinking of the urethra from the bladder falling out, and that is literally like kinking off a garden hose. So it very well might be.
And it also that you feel like your bladder is not emptying all the way because you feel like you're peeing all the time or you have incontinence. And so sometimes it's really that it is emptying. It's just that you have, symptoms of overactive bladder that are making you feel like it's not emptying.
We'll go with that one.
Is physical therapy required prior to surgery for stress incontinence? Not necessarily. Sometimes we can actually see stress incontinence on exam when we're doing our physical exam for our workup. And sometimes if we need to do some additional testing here in the office called urodynamics that I think is on a later slide, just to prove the stress urinary incontinence. But if you actively come in or you come in and you show it on exam, then sometimes you don't even need to do additional testing.
If I have a non-mesh surgery for stress incontinence, that's the sling that we do with a biologic material. Can my partner feel the sling? Absolutely not. What happens with the biologic is it's completely replaced by your own body's natural tissue over a certain amount of time. So obviously within the first 4 or 6 weeks, when you're not supposed to be having vaginal intimacy, it can be, the suture line can be felt. But once it's healed, there's absolutely no sensation from the graft that we use. The biologic graft is completely gone, replaced by your own body. So Kelly, do we have a couple other, I think we have time for.
Yeah, we've got a lot of questions. We'll get to a few of them now, and I know we've still got a little bit more of the presentation to go through. So let's jump into a few. Can you describe what is the primary or main cause of an overactive bladder, and does it typically occur more as you age?
It does, but it's actually widely. I have a slide, not in this slide deck, but a slide where the distribution is across all age groups, and it does increase moderately as you age, as most things go wrong as we age, and we don't really know the cause. We just the sort of the traffic between the bladder and the brain as you age, the nerves, the signals, they just don't work so well because we are constantly telling our bladder to relax. It's a muscle that always wants to contract, and we're constantly telling it not to. And you just kind of think that pathway, that those railroad tracks, or as we age, don't work so well. We don't know what causes it. We just don't have a great idea what the etiology is.
So there's some factors that contribute to it, such as health issues as we get older, like hypertension and diabetes and things like that. And sometimes it's something that we're insulting to our bladder in general, such as drinking, a gallon of water or more a day. If that's, too much sometimes for people, like they'll increase their water because they're have diabetes and they're constantly thirsty, or they're on other medications for their blood pressure or other reasons that makes their mouth dry, so they continue to drink more water. So sometimes it's something like that, dietary wise, that's contributing, and sometimes it's just our habits. We allow ourselves to go to the bathroom more frequently because we're afraid of the consequences. And so we don't give the bladder enough time to fill up and stretch out like the bladder muscle can do. And so it's constantly like you're training it that every time you have just a small amount of urine in there, that you're wanting to go to the bathroom. So it's kind of contributory factors, but not true causes that we know of.
And we didn't talk any about interstitial cystitis tonight, but as an underlying condition of the bladder, if you hear that term, or if you have this urgency and frequency, we often look for that as a underlying condition. It's the lining of the bladder just isn't sufficient to keep the bladder from being irritated by everything you put in it. So we won't talk about that today. Kelly?
Okay, thank you. Is it normal if a person is a little bit wet sometimes, but they're not necessarily losing urine due to like laughing or coughing or things like that?
It depends on what the wet is. Is it fecal stooling? Is it vaginal secretions, or is it urine? If it's urine, no, it's not normal. In other words, losing urine, which is the definition of incontinence, is not normal. Is it okay? If it doesn't affect your quality of life and you don't mind it, then it's okay and normal for you, but it is not a normal condition.
Thank you. So this person writes, I only have issues at night. Does this fall into a category of needing to be seen by a doctor?
So getting up at night, as we said before, it affects your REM sleep. It's a safety issue in some people, but it definitely is in the realm of overactive bladder that can be treated.
Yeah, and if you get up at night to pee frequently and you sleep all day because you have that luxury, then it's probably not a problem. But as Sondra says, if it interferes with your sleep, yes, you should see a provider for that. Yes, absolutely.
Okay, great. Um, does a bladder suspension surgery wear off over time? This person had one over about 30 years ago.
Um, yeah, nothing we do today it shouldn't surprise you that anything we do today isn't still working 30 years from now. It's no surgeon should ever tell you the knee I put in is going to last you a lifetime or the dental implants are going to be forever. 30 years is a long time, and if it's starting to fail at that point, then that is actually not that uncommon.
Um, this person says their insurance doesn't require a referral, but do you prefer patients to see their primary care provider prior to contacting your office for an appointment?
No, that's not necessary. If they have symptoms related to their bladder or prolapse, you don't need to see your primary care first and try something. We can always start the workup from the beginning for you and get you in the right direction to get you happy with your bladder again.
Are referrals ever needed, or is that just insurance dependent?
Insurance dependent.
Okay. And does your office currently accept new patients?
Yes.
Perfect.
This is why I tell everybody come in tomorrow for an appointment, but I'm not going to say that.
Can
You're
high
not here tomorrow and I am, and that's not fair.
um okay. Can high blood pressure medications cause an overactive bladder?
Great question. No strong link. No. But high blood pressure medications such as diuretics, where you're
Yes.
filling your bladder, it's filling your bladder frequently, can cause frequent urination. So that group of medications, diuretics, absolutely can cause an overactive bladder. Is it still an overactive bladder because you keep filling it because you're diuretic? Technically, yes. Yeah. It's a good question.
Okay, great. What kind of advice do you have for a young person who's experiencing these issues due to trauma?
Well, it depends on what type of trauma. There's psychological trauma and there's physical trauma. Uh, so that would be the first question I would have is, are we dealing with a psychological trauma? That's a very complex answer, which we absolutely have no time to get into tonight. But yes, you should see us for either way. If you've had physical trauma, all of the therapies that we talk about are still available to that person too.
Okay, great. Um, can you describe what PT looks like for an overactive bladder?
No. No, they are experts at this. And I'll let Sondra go away with this.
So a lot of times, and from personal experience, you think you're doing the Kegel exercises correctly, but you're not always utilizing the right muscles inside the vagina that's needed for you. A lot of patients think they're doing the Kegel exercises, but they're actually using the buttocks muscles or even sometimes the upper thigh muscles, and they're not really training or contracting the pelvic floor as needed. So they work a lot externally to teach you exercises. They do some internal work. Sometimes they do some biofeedback where they use like a stimulation to try to get the muscles to contract for you, but they teach you how to do the exercises that are necessary for your particular pelvic floor and your muscles.
It requires biofeedback, and that's what
Yeah.
they're really good at. And we do not have that expertise in our office, nor do we try. I like to just sort of tell a little story. The body is designed to have a flight and fight response, getting it, or a rest and digest response. And they're always in competition. And one of the things to remember is if you are running from some animal trying to eat you, you don't stop to pee. And so that system, and that's why kids do a pee-pee dance when they have to pee, because they're doing all these things with their muscles to give the bladder a chance. It tells the bladder to relax, get out of the game because I'm about to get eaten or something's going on. So they rely on this system that's already in place in everybody to really bring it into focus, to retrain your mind and your muscles to help your bladder relax. And they're very good at it.
Perfect. And is pelvic therapy the same as physical therapy for an overactive bladder?
So it's actually pelvic floor physical therapy. Like you need to see a specialist who just works with the pelvic floor. So all of the people that we refer to, they're females taking care of our female patients, that they're very familiar with just the pelvic floor.
Okay, great. And are there any exercises that you can do like outside of, going to a therapist's office to help with urinary problems?
I strongly recommend I'm sorry. I just strongly recommend starting with a physical therapist. They will give you the exercises to do.
Right, and instruct you. But again, the home pelvic floor devices that are available, we need something that can give us feedback back did you like that? That you can actually see on a system. So one, for instance, is called the PeriFit, PERIFIT. And with this home device, you set it up with your app, you can order it online. But it actually plays kind of like video games in a sense, so that if you're not squeezing appropriately, you're not going to get the little thing to jump or to run forward. And it just gives you some feedback that you're actually doing the exercise correct. There's other pelvic floor devices that are out there that, again, you can do them till you're blue in the face, but they're not really telling you that you're doing them correctly. So you would need a device that does that. Again, there's Kegel exercises and you can read about how to do them, but if you're not utilizing the muscles that you need, you're not getting the appropriate therapy to really help you.
Okay, great. And I do want to move on to the next section of the presentation, but we've got quite a few questions about Kegels or Kegels. Is there any recommendations that you have for like how to learn how to do Kegels appropriately? And do they actually help with strengthening, your system to be able to hold urine longer?
Yeah, so they help because they shut off the signal to the brain when you tighten up, because it's like doing the PB dance that Dr. Duncan said that little kids do. And it tightens up the pelvic floor and shuts off the signal to the brain so that you buy yourself more time to either let that pass or to get to the bathroom on time. The only other way that I can tell you to appropriately do it without either using a specialist like a pelvic floor physical therapist or one of the devices that you can purchase at home is you would need to come in the office and we can actually show you with an exam if you're actually using the muscles that are needed. But you really need somebody who's specialized in it to make sure that you're doing them correctly.
In essence, a Kegel or Kegel, either way it's pronounced correctly, is not a Kegel or Kegel unless there is biofeedback involved by definition. So don't think that just because you're squeezing your muscles, you're doing Kegels. You may be, maybe not. So it is required, biofeedback is required all the time. No, once you learn it, you learn it. But it is a requirement to do it correctly.
Perfect. All right, let's pause there on questions and we'll go ahead and move into the next part of the presentation.
Okay, we're going to talk a little bit about pelvic organ prolapse. Essentially, that's the medical term for when things start falling out of the vagina or the rectum. This is our practice profile. We do a lot of surgery. And Sondra does a lot of in-office work on both our prolapse patients and incontinence patients. We again mentioned we don't use any synthetic mesh for even our prolapse repair. Of course, the FDA has banned it finally, but we have been non-mesh for about 12 years now, give or take.
Yes.
So this is a startling fact. This is again a topic that you don't go to cocktail parties and talk about. So you may think that you're unusual to have prolapse, but it's not. 11 to 32% of women will seek treatment for it. That's a lot of women. Just a kind of reminder, I use my little hand as a model and 3 compartments. The bladder sits here, the uterus, that's the top, and then the bowel down here. So the 3 compartments, anterior, apical, and posterior, where the bowel is. And these are the different areas where you can have prolapse. And then again, you can have rectal prolapse also. And we think of the vagina as three compartments, and Sondra hates it when I use my hands to demonstrate this. She has a little computer model that she pushes buttons and whoosh, it comes down. But the three compartments are important to remember because you can have prolapse in any one or all three, and rectal prolapse or any just one. And we think of them differently because the support structures for each of those compartments is different. These are risk factors involved with prolapse. There are those who have never had a vaginal delivery and none of these risk factors who have prolapse. There's probably a difference in prolapse patients with their connective tissue, but it doesn't mean anything else in terms of your general health. It's just that in that area, your connective tissue, the things that hold things together, may not be the same as someone who doesn't have prolapse. This is, I think this might be from one of Sondra's little models. I don't know. But these are just some examples of, this is a person standing up, the legs are down, head up, bladder, uterus, large bowel and rectum. And these just show some of the prolapses that we see. This is the uterus coming down that we will see in the office. Again, this is just a cartoon example of the prolapse of the uterus. Used to be here. You push down and it comes out there. Treatment options. You can do nothing. If it doesn't bother you, unless it's way out, we do nothing, because if it's not bothering you, it certainly isn't bothering us, and we do not need to do surgery. Physical therapy can also help. Will it fix the breaks? No, absolutely not. And so, if I have a hernia in my belly button, I can do sit-ups till I have a nice six-pack, but the hernia is still going to be there. I may feel better. I may feel good enough to avoid surgery, but it will not fix the actual prolapse defects. Pessaries. Those are the little rubber donuts that we can put into the vagina. Sondra has a huge pessary population, and she's probably, I would say, the regional expert at this, getting things to hold up. Do they work for everybody? No, or else I wouldn't be doing surgery. Surgical options. We do almost all of our prolapse surgery vaginally, simply because it's the safest way to do surgery. A lot of surgery is done laparoscopically or robotically, and we do a lot of laparoscopic surgery too. But to get a comprehensive repair of all the compartments, anterior, apical, where the uterus is, and the bowel, the best approach is a vaginal approach. It's safer. It's impossible to reach well, not impossible, very difficult to reach the posterior part from a laparoscopic approach or robotic approach. So robotic approaches are great for the apex, the uterus, but not for all of it. It's also safer. And just a sidebar, I don't think we have a slide about hysterectomies here, but almost never do you require a hysterectomy to do prolapse repair. That's a misconception that the uterus has to come out to fix any type of prolapse. Sondra, you want to talk about?
Yeah, this is just another home device that you can purchase. Actually, you need an order from the office for this particular one. Again, it's you purchase the app and they send you a little device that you actually would put inside the vagina, and it actually will help to strengthen the pelvic floor for overactive bladder, stress incontinence, or just the actual muscles of the pelvic floor in general. It is sometimes covered by insurance. They will check the company itself. Once we send the order over, they will actually check it. It is a very good device in the sense that it gives you great feedback. I will tell you that I did try it when it first came out many years ago. And it was a little difficult to learn how to do it at first because, again, it's very soft and you don't feel it when you put it in the vagina. And so it just took me a while to get the process itself. And then once I had it, I don't even need to use it anymore. I can, if I have some feeling of urgency, I can just go ahead and do the actual muscles, and I really know how to strengthen my pelvic floor, and I'm able to eliminate the urge and get to the bathroom. This is for the pelvic organ prolapse. Some of our patients aren't able to, or, can't have surgery right away. This FemiCushion is just a small device that you actually, that's you would put that ball into a pad that you order through the company itself. And that just gives you some support of the prolapse externally so that you don't have to have a pessary to push it in. It just helps to relieve some of the pelvic pressure that occurs with some prolapses. And it is, again, something you can just order online. This is just another picture of the same thing.
So when do we treat? Just again, sidebar, don't confuse prolapse with function. If you come to us complaining about the functioning of the bladder, even if you have a little prolapse, we don't need to jump to surgical treatment or any treatment for your prolapse if the prolapse itself isn't bothering you. What do we mean? You feel like something's falling out, pressure, difficulty walking, back pain sometimes. So the function of the bladder is a separate issue than the prolapse. The best treatment, which works 100% of the time, never fails, and has no risk and easy recovery, that treatment does not exist for anything. So don't let a surgeon ever tell you, I have 100% fix for you. These are pessaries, and again, I talked about these rubber donuts, these things, these occupiers that we can put into the vagina, or Sondra puts in the vagina. She has a large pessary practice, and they sometimes help. They don't always, and when they fail, that's when we move to surgical options. This slide here, we are going to skip over because it's too complicated for me to even talk about. And this, again, a reminder that vaginal surgery is safer than any other type of surgery that we can do, including robotic or laparoscopically. This is a statement that is supported by all of our mother organizations down here. It doesn't mean you shouldn't have laparoscopic or robotic surgery. It's just that you should be considered for the option of vaginal surgery in almost all cases of prolapse. This is, again, just a slide about mesh. You all have lived through the mesh debacle where we saw attorneys every night on the TV talking about the harm of mesh, and mesh was not a good thing to put in the vagina. We did it for a lot of years, and we're almost at a point of being apologetic to our patients for ever having gone down this road. But again, as we have mentioned, we have not used mesh for quite some time. Again, this is just some information about mesh. It's still available for slings, but again, we do a non-mesh sling using the same principles, exact same placement as a mesh sling. It doesn't mean mesh slings don't work; they do, but it entails putting in a piece of plastic in the vagina. And again, just a brief note that mesh, even for slings, it's still available for slings for treatment of stress incontinence in the US, but a lot of other countries have banned it completely, even for slings. Our FDA has not gone that far yet, but they'll get there probably. I think we're going to get to some more questions, right?
This just reiterating, we don't use any mesh in our office at all. We haven't used it for over 10 to 12 years now. We just use the biologic products.
On a rare occasion, we will have a patient requesting mesh for a sling, and we will put it in if that's what they really want, because the mesh sling for stress incontinence is a tried and true procedure. And on occasion, we have a patient says, I still want that, not the graft. But that's incredible. Once every 5 years, 4 years, we'll do that. But as Sondra said, we just don't use it. We don't need to. We've had great results with biologic material. I think, Kelly, we're back to some questions. We have a good 10 minutes, almost the right amount of time.
Wonderful. Yeah, we've got a lot of good questions. That was a lot of great information. Thanks for sharing that. Let's jump in. So would an annual OBGYN exam detect prolapse?
Great question. Let's just say generalist and OBGYN or GYN generalist are kind of all over the map, as are primary care doctors. There are internists who can diagnose it quite well. There are GYNs who diagnose it quite well. I would say as a general rule, yes. They are trained to do so. So yeah, the answer is yes. Sondra, you look at me.
So typically, yes, it's I guess our exam is just a little bit different. A lot of times when they're doing the annual exam, they're going in to look at the cervix to do a pap smear. And, sometimes if it's not a large amount of prolapse, sometimes they don't always see it. Again, prolapse, the more you're standing, the gravity and things, some days it's going to be worse than others. So some days it doesn't show up as easily. When we do our exams, we try to do it in different positions. We also use just a half a speculum and evaluate each wall individually. And so sometimes that's a reason why sometimes it's not seen in the regular appointment with the GYN. But typically they're the ones who send us a lot of the referrals that the patient has prolapse, and they send them to us for correction.
And I might add, this question might be one where someone's saying, I feel like I have prolapse and I was told I didn't. If you feel like you do, pressure, something falling out, you probably need to be examined by our office or another urogynecologist office, because that's our expertise. And yes, it can be missed, but sometimes missed legitimately because it just wasn't protruding at the time you had that examination, as Sondra said.
Great. Is it harmful to occasionally push back in a prolapse?
Yeah.
Not at all. No.
No, it's not harmful at all. It's not, the prolapse isn't going to twist or isn't going to herniate in any way. It just some days feels worse than others. And sometimes that's all patients will do is when it's out further, they just push it back in, and you can't harm anything.
And that patient might be a great patient or a candidate for a pessary.
Yeah.
Good to know. Thank you. What might cause the uterus to prolapse?
Childbirth is our biggest factor, but gravity and aging is going to take its toll on all our parts. And so there was a slide we had in the back which talked about other risk factors. Paratroopers in the Army, female paratroopers, high rates of prolapse because they're hitting the ground, and chronic constipation, chronic, weightlifters. They're all increasing this abdominal pressure, which increases their risks. But childbirth is our major risk factor.
Makes
Vaginal
sense.
child.
Yeah. Okay. What category would a person fall into if they're just not able to hold their urine as long as they used to be able to?
So usually that one will fall in the overactive bladder category. But again, you would need evaluation because sometimes it surprises us and there might be some prolapse that's there, or, some other reason the bladder's not emptying all the way. So it just would be helpful if we were able to pull it apart and evaluate it for the patient.
And it might be that you're still very normal. Let's say you used to be able to pee 3 times a day, and now you pee 5
Sure.
times a day. You're still normal. So the cutoff is more than 8 times in 24 hours as a general rule. So if you say, I used to hold my urine for 6 hours and now I can only hold it for 4, and you come in and complain about that, we're going to go like, okay. I mean, that's not necessarily a diagnosis.
And is that like 8 times in 24 hours? Is that based off of, I forget what the actual recommended number of ounces to drink per day is, call it like 64. Is that kind of based on like that rule of thumb, or where does that number come from?
It's just our clinical diagnosis, and it's just a general rule because there are people like Sondra who drink water all day long, and one of the first things that she'll do is, of course, go through that dietary and liquid consumption, and sometimes we just need to cut back some. So it's a great question, Kelly, whoever asked that question. And yeah, it's a combination of what's normal and what's too much drinking and what's too much caffeine, and are you on a diuretic? And we'll just sort of have to skate through that. You pee 9 times a day and never have to get up at night, and you're on a diuretic and you drink a lot of caffeine, that's about as good as we're going to get.
Yeah. There is a question here about coffee drinking. So is that a contributing factor to overactive bladder?
So it can be as far as caffeine intake, coffee intake, whether it's decaf or caffeinated. A lot of times it's the acid that's in the coffee that is a bladder irritant to some people. Some people can drink coffee and they don't have that same problem. But there's if you just look up bladder irritants in the computer, you'll see there's a whole list of things that are irritating to the bladder that can be irritating. It's just your triggers might be different than somebody else's, but coffee will make you pee.
I'm drinking my chamomile tea, so I'm okay. But it is a weak diuretic, so it's probably not going to fill your bladder for you. But it is, as Sondra said, can be irritating, especially in patients with interstitial cystitis.
Okay. Could you explain neuromodulation again?
The best way to say it, it's a fancy term of saying that signal going to your brain to tell you you're about to pee, I'm going to interrupt it. I'm going to put a little battery with a wire that goes along the nerve that's sending that signal up, and I'm going to disturb it. Best analogy, you're hammering a nail and you hit your finger instead of the nail. You're getting a pain, you're going to start having some pain signals. The first thing you'll do is neuromodulate that pain by doing this. So that's classic neuromodulation. Old school nurses pinch you on one cheek and give you a shot in the other cheek. Neuromodulation. You're storming the beaches at D-Day, and there's all kinds of things going on, noise and guns and bombs, and everything settles down. You notice then you've been shot. Neuromodulation. We're just confusing the signal. So that's what the neuromodulation for the bladder will do. We just will confuse the signal that's going to your brain by sort of massaging it with a little electrical pulse. We don't really know how it works.
Well, that sounds like a good place to start. Do you have any insight on the use of Gemtesa or Botox for overactive bladder, like any safety considerations or your experience with the quality of life?
So Gemtesa has very few side effects. It's pretty safe. It doesn't cause the dry mouth, dry skin, constipation. It can raise your blood pressure just a little bit. We haven't really seen that in our practice for as long as we've been using it. It's, pretty good success. It works a little quicker than some of the older versions of the medication. And with bladder Botox, one of the side effects that we are always looking for is urinary retention. So just like Botox, when you have somebody has wrinkles in their forehead and they get Botox and it relaxes their forehead, this is going to relax the bladder with the bladder Botox and allow it to fill more, to store more, and to be able to empty a little bit better for you. The problem is that if you fall into the small group of 4%, which is not negligible, but if 96% of patients won't have urinary retention, but urinary retention is one of the major things that we are looking at when patients are getting Botox. If with Botox also, we have to consider, are you getting Botox someplace else in your body? There's a 3-month maximum amount you're allowed at one time, which is 300 international units. So if you're getting Botox for migraines, and then you're getting Botox in the bladder, we need to know how much you're getting for the migraine so that we don't give you an over amount of the Botox in the bladder. The second would be with bladder Botox is a urinary tract infection. If you are having a urinary tract infection or symptoms of, we can't give the Botox at that time because it won't work as well for you. And so we usually pre-medicate the patients with antibiotics before we do a Botox injection.
Perfect. That's great. Thank you. Are there any major signs or signals that a person should look out for to know this is when I need to seek medical attention for either prolapse or for any incontinence issues?
When it bothers you. If it bothers you is when we need to see you, because we can't help you if we don't know. But if you're bothered, then it's worth looking into. It doesn't mean you have to accept any of the treatment, but we can at least give you a good evaluation if treatment is absolutely necessary. If you're not getting sleep at night, or you're living by knowing where every bathroom is from here to wherever you're going and back again, then it might be time for treatment.
And sometimes we are not the best judges of what's really bothering us because we accommodate and we soldier on. So oftentimes a patient will say, oh, I'm not bothered. I don't get up much. And the husband will sit there, or partner will sit there and say, yeah, you do. I get up, you wake me up 6 times a night. And so the patient's thinking that she's not bothered, but other people can tell her she is bothered. Classic example. I stopped going to funny movies because when I laugh, I pee on myself, but I'm not bothered. Well, no, okay. We can make accommodations to make ourselves feel not bothered, and sometimes we need to ask other people, am I doing too much to accommodate so I can say that I'm not bothered? So, but Sondra's quality of life. If you're not bothered by it, don't come see us or see anybody. These are not life-threatening problems. These are quality of life problems.
Also, if you're stopping your fluids when you go out, or not drinking anything all day because you don't want the symptoms to occur, you might want to reevaluate to see if it's bothering you.
Perfect. Thank you. That makes total sense. If a person is experiencing constipation as well as some bladder concerns, will constipation be addressed with repairs to the bladder?
It's a great question and a little complex, but repair to the bladder should not affect constipation because we're operating on the upside and the bowels are down. If we're repairing the downside, yes, constipation, we can worsen it. But Sondra does this magical thing with our post-operative patients that helps to deal with that. But chronic constipation can also be a contributing factor to prolapse. So it's a really complex question, and it might get worse. We might be able to help it. But we also can sometimes fix constipation because in that posterior compartment where all the bowels are, if there's a lot of room, stool just gets down there, and when it gets down there, it gets the water reabsorbed, and it get really, 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 really hard. And so prolapse can be a factor in constipation, but we don't always fix constipation with prolapse repair. I know it's a kind of rambling answer, but I don't know if you have anything to add, Sondra.
Yeah. No, that works. Thank you. If a person's experiencing overactive bladder but not incontinence, would you recommend they see a urogynecologist, primary care, or OB/GYN, or somebody else?
Excellent question. Anybody can start the treatment for routine overactive bladder. Most primary cares are great at it. As a matter of fact, most prescriptions given for overactive bladder are not given by urogynecologists. They're by primary care because they see more patients. Secondly, generalist and GYN, OB/GYN, because they see more patients. So it's a great question. And no, you don't have to come see us for that first treatment for your OAB.
Okay, great.
You can if you want to.
Are there any preventatives for overactive bladder, like anything you can do to prevent this from happening?
It's a good question. And, again, having some insight as to whether or not your bladder is being bothered by these irritants that we might look at, not really. Will pelvic floor muscle tone help? Probably some. But it really is, when you talk about 33 million people, if we had a magic preventative measure, we would use it and have that number much less, but we just don't. So it's again, a good question.
Yeah. Is wine also an irritant for overactive bladder, or any alcohol, I suppose?
It can be. Again, the irritants to the bladder are as individual as we are. So there's a big list. Like I said, if you looked, I just looked up bladder irritants on the computer, but basically you have to find out what your triggers are. So some people can tolerate coffee, and some people can tolerate tomatoes, and other people can't, so you kind of learn what your triggers might be as you look at things that possibly could be irritants. But it's different for everybody.
Okay, great. If a person has been having issues with overactive bladder, but they're also undergoing treatment for breast cancer, can they still get treatment for overactive bladder while they're, dealing with that at the same time?
Yes.
Absolutely.
Yes.
Perfect. Will prolapses get worse with age?
Most likely.
Yeah, because gravity's not stopping. And so, yes, they generally will. No good studies on just sort of following people conservatively. but you can sort of kind of assume that, yes, they get worse over age. Will they ever get bad enough that it requires surgery? Not necessarily.
Okay, great. We have a couple of questions about pessaries. So if a person has a pessary, but it slides out whenever they sneeze or have a bowel movement or something like that, like what can they do to make that stay in place?
So the pelvic floor exercises are helpful. Sometimes they just need to be refitted to see if they have the appropriate pessary in. Sometimes we can add a stress pessary to not that you'd have two pessaries in at once, but just add a different style of pessary that might also help with that. So a stress pessary basically is a round circle and it has like a little knob on it, and that knob would actually help to support the urethra. So that might help with the prolapse and also help a little bit with the stress incontinence that happens. And maybe it will fit a little bit differently.
Okay, great. And along the same vein, so this person is having some thinning of the bladder wall and also has prolapse issues. Is the pessary an option, or at what point should surgery be considered?
The pessary is still an option, whether they have atrophic vagina, thinning of the bladder or of the vaginal wall itself, as long as the pessary isn't causing any irritation to that wall. So when you lose estrogen in the vagina and you put a device in there that's made out of silicone, which is your pessary, if it is rubbing too much or it's not properly fitted correctly, it can cause some irritation or to that thinning wall. Sometimes we need to add a little bit of estrogen to help that wall. So there's it just depends on the fit. It just depends on the patient's prolapse, and what we are looking for when a pessary is considered a failure is when the pessary doesn't stay in at all, or it's causing some of these irritations to the vaginal wall, or the prolapse is worsening and we can't stop the prolapse from coming down with a pessary. And some people will love the pessary and use it forever and ever and ever. And other patients, because a lot of the pessaries are managed by me and not an individual or the patient actually doing the care for the pessary by themselves, although some people can really do really well on it for years and years and years. Again, it's just that a time constraint. Most of the pessary patients come in back for follow-up every 3 to 6 months, depending on the style of pessary. So that becomes bothersome and they just say, I'm ready to do surgery, and we move on. And others are like, I'm good. I'll come back and see you every time and let you take care of my pessary. So it's individual.
Wonderful. Thank you for that. It Where would you recommend starting for issues with overactive bladder and incontinence? Is it like a physical therapy, or are there other places that you'd recommend starting your kind of treatment journey for that?
So I guess when you come into the office, if you were coming to see me, I try to go over dietary things first, and things that, as far as how much you're drinking or what you're drinking, or the bladder irritants and things like that, to see if we can do some behavioral changes with that. Sometimes it's important to learn how to take control of your bladder by not giving in every time that your bladder is telling you that you have to go, to see if you can kind of train the bladder to hold it for a little bit longer, which will allow the bladder to stretch a little bit more and learn over time to fill a little bit more. And then, we work it from there. What is in the best interest of the patient? Is it medications? I can offer physical therapy, but if it doesn't fit into your schedule, or you're not going to be consistent enough. I mean, we all know, like, we have that treadmill sitting there and now it's folding clothes, or it's, have some other source. So if we have the exercise equipment and we don't use it, then it might not be the best therapy for you. We have a lot of people who say, I just can't go because of my job and my hours and my kids and my life, and they don't go to physical therapy. And so maybe some of those patients would do the home devices. And other patients are like, we just try to give all the beginning options first and then work our way through, the whole process to to get you happy with your bladder.
And also that question also may also pertain to where do you start, your generalist, your GYN,
Oh, okay.
start with
Sorry.
physical therapy? Do you start with your primary care doctor? And the answer is you can start with any of them as long as they have expertise or some concentration or interest in this type of problem. And if your family practice person says, I got no clue, then, and you shouldn't be afraid to ask, do you know urogynecology? You don't have to go to a urogynecologist to get urogynecology care, but the provider providing it to you kind of needs to know what he or she is doing. So don't be embarrassed to say, hey, do you know urogynecology? Do you know the difference between the different medications for OAB? Do you know that? If they will say in a heartbeat, not my thing, I will send you to urogyne. So it's a great question, and it really depends.
That's a good recommendation. Yeah, to have some questions prepared when you go into the appointments
Yeah.
and things like that. That's a great idea. We're down to our final question for this evening. There's been a lot of really great questions coming in. So this might be a Dr. Duncan question. Can you talk a little bit about the like when you have surgery for prolapse or any other bladder type surgery? Can you talk a little bit about what the recovery time is like for them? Are they typically inpatient, outpatient procedures? What kind of pain medications would you offer? Particularly if there's any like natural pain relief medications or recommendations that you have.
It's a funny thing because it's so not a Dr. Duncan question. Sondra is the
Oh,
that's why she's
my bad.
perfect.
Sorry.
I will do the surgery, but in terms of all the recovery and questions, that's her. But I will start off by saying we try not to do too many narcotics because of everybody knows that there are issues with that, and most patients don't require them after surgery. But short of that, Sondra will tell you all about the recovery period and what to look for. I'm literally her technician, as she likes to describe me. But
Not my technician, my mechanic.
Oh, your mechanic. That's right. But yeah, she is actually the one who, I mean, she sees the patients after surgery. She knows the constipation. She knows the pain levels that are going on. I'm back in the operating room, so she'll answer that, I think, better than I can.
Fantastic. Thank you.
I'd say, to go with some of the questions that you had, we basically give you a surgical packet once you've made a decision that you want to have surgery, and our surgical scheduler has a date for you. She will give you pre-printed instructions from A to Z, everything you're allowed to do, everything to expect. We also do a pre-surgical visit, either virtual or you come back in the office and I review over those instructions just to make sure that I give you some little things that have worked for patients in the past. Typically at 2 weeks, you're about 80% back to yourself. And at 6 weeks, you're about 90 to 95% back to yourself. In the things, that you're allowed to, or not allowed to do, I should say, is we don't allow you to do anything that's going to pull on your vaginal stitches. So we don't like bending or squatting or lifting more than 10 pounds for the first week, sometimes 2 weeks. You have to be able to bring your knees up towards your chest without any pain in your vagina or your tailbone before you are able to drive again. As far as pain management, like Dr. Duncan said, typically there's narcotics available if needed, but I would say most of our patients don't take the narcotics. They usually do either Tylenol or Motrin, or alternate between Tylenol and Motrin. We've had used gabapentin and Flexeril, sometimes just to relax the muscles of the pelvic floor to allow for better pain control that way. A lot of the patients will do like a sitz bath, or they'll use a shower head to kind of to the vaginal area, because all your surgery is done through the vagina, to just kind of decrease some swelling and increase some comfort. Patients will use some lidocaine patches to their tailbone area just to kind of help with some pain that you get in that area. Constipation is the biggest issue that patients will have after surgery. So We do usually recommend that you're doing stool softeners to keep the bowel soft, and then starting a laxative that you would, use if you haven't had any bowel movement in 3 days. We start with laxatives, or we'll move on to enemas if needed. But most people, if they're starting a mild laxative, something as simple as smooth move tea or milk of magnesia when they get home. We recommend the week before surgery that you're not eating things that are hard to digest. So you can still eat all your things, but like cooked vegetables instead of raw vegetables before surgery, just to help the transition for right after surgery, for that to be a little bit smoother for you. Having your first bowel movement is like after a delivery of a child. It's, it takes a little bit of effort, and, sometimes you just need a little help to get by with that. You're able to go up and down stairs. You're able to walk distances. You can be a passenger in the car and go places if you like. The hardest thing is sitting. So we do, recommend that you're sitting on some type of pillow or a donut, just to give you some additional comfort measures there. Were there other specific ones that you were saying, Kelly? Before I kind of
I may interject that the recovery for a sling procedure for incontinence is much less than
Oh
the.
yeah.
No, it's just.
Yeah, those patients, usually I'm trying to call them about 2, 3 days after surgery, and they're like, hey, I'm at the mall, or because they're doing, that's just a little minor surgery. I was just referring to the prolapse repair itself. And everyone's prolapse surgery is a little different. Some people need all 3 compartments fixed, and other people just need 1 compartment fixed. So it varies on the extent of the prolapse and the amount of repair that he does also. The stitches are dissolvable. We don't take any stitches out. Over time, it usually takes anywhere between, I would say, 6 to 8 weeks before those stitches truly dissolve.
And
Is there
another
another?
sidebar that I forgot to mention, when we do most of our surgery vaginally, it's not that we are against laparoscopic or robotic surgery, but even our laparoscopic surgery is done vaginally now too. So it just it sort of gets around the fact that it gets around needing to put scars on the belly. So just got to mention that earlier.
Fantastic. No, I think that answers the question perfectly.
But it's all written out, and it's all written out. Like I said, you can just look in your packet and it'll say bleeding. Oh, it's not more than about an hour. I'm okay. This is going to happen. Or, what I can do for constipation. It's all in the post-op instructions. But we get calls all the time to just go over, questions or concerns that the patient's having post-operatively.
Perfect. That's very helpful. Okay. Well, I think that's all we have for today. That was a lot of great questions from the audience. If you think of any additional questions or you'd like to get some more information, you can reach the Ascension St. Agnes Urogynecology office at the number on the screen. That's 667-234-6885. Or you can also find more information on ascension.org.